Hey team, I thought this was the best way to send over the presentation to you. I did not want to interrupt the workflow and rounds. Today we're going to take a look at the bacterial endocarditis and the question of whether or not to use PO versus IV. So the question is to PO or not to PO. That is a question introducing the PO trial, which has discovered this topic. So taking a look at the endocarditis, there are three different types: bacterial versus fungal versus non-infectious. We will be taking a look at the bacterial infections, most commonly caused by Staph aureus, Streptococcus viridans, and Enterococcus. And for the non-infections, if you're interested, this is usually caused more so by autoimmune diseases such as Lieberman-Sachs, as well as lupus, for example, and certain medications. So who are the players? So have a heart. Let's take a look. So in terms of right-sided endocarditis, we have Staph aureus, Pseudomonas aeruginosus, as well as the Candida species. These are usually caused by IV drug users. So for example, Staph aureus and Pseudomonas aeruginosus is most prevalent, but we can also find that Candida species are present in central venous catheters. So taking a look at the left-sided endocarditis, we have the Strep viridans, which causes subacute infections from dental procedures, Staph aureus from acute endocarditis, from prostatic valves, Enterococci, which is a mix caused by gastrointestinal as well as GU tract diseases. We also have the Hay-Sachs group of organisms, which are fastidious gram-negative bacteria. Take a look at the pathophysiology. And here we can freely discuss a few things. The right side of the heart usually sees blood from the superior and inferior vena cava, and as we mentioned, those are the ones that are more prevalent in IV drug users, especially Staph aureus. As we have learned from Morris's case conference, that it is not really the bacteria that originally just settles on these valves. There has to be some kind of inciting event. These inciting events are usually from other species found within the IV drug use injections. I've learned in my research that talc is one of those common things that can settle on the tricuspid valve as well as the pulmonic valve. Over time, it causes damage to the valve itself, and that causes the deposition of fibrin, causing the clotting cascade to start. This creates a cascade and almost like a scaffold for infection to settle and bacteria to settle and cause there to be more like a cascade for the bacteria to actually continue accumulating and cause damage more to the valve. And that is more so seen in the tricuspid and the pulmonic valve. In terms of the left side of the heart, as we can imagine compared to the right, the left side of the heart is under higher pressures. So the left ventricle alone sees almost 120 millimeters mercury systolic, while the tricuspid valves, sometimes from the atrium, sees more so 10 to 15. But imagine that even with tricuspid regurg, the valve will still see some part of that 120 systolic. So usually because there's so much turbulence coming across valves, especially if there's damage to the native valve, we can imagine that the valves can become damaged. Once again, they can start their own cascade of fibrin, clot, and immune complex depositions. And now when we add bacteria to it, this causes a scaffolding and accumulation and biofilm deposition. So usually that's the difference between the right and the left side of the heart. Taking a look at the workup and treatment, we know that we will get two sources of blood from two different sites in order to do our bacteremia workup and blood cultures. We will also get a TTE to look for any vegetations. If the TTE is not conclusive, we will basically go for a TEE to really see if we can visualize a vegetation either on the left or the right side of the heart. Interestingly enough, through my research, I was interested to know if we were going to start any anticoagulation in case there is a thrombotic event that goes more peripherally. In the case of bacterial thrombosis, we actually don't treat with anticoagulation. That is more so reserved for cases of AFib as well as other clotting disorders and clotting events, but not in the case of bacterial thrombotic events. So most of the research that I found pretty much mimics this title. evaluation of a paradigm shift from intravenous antibiotics to oral step-down therapy for the treatment of infectious endocarditis. And really, we will not start PO therapy without starting IV therapy first for approximately 7 to 10 days. And that is because we want to actually, which we'll discuss later, to have to get a peak maintenance concentration of the antibiotic within the blood. So basically, most of the research that I've taken a look at is really taking a look at the transition of intravenous antibiotics to oral step-down therapy. So the question of PO versus not PO, we can use oral antibiotics, but we really do want to start with intravenous antibiotics at first. So taking a look at the pathway of IV versus PO, if the following questions can be answered, we can actually continue with IV, but as soon as we can transition to PO, we will transition to step-down therapy. So for example, questions like, is the patient clinically stable? If not, continue IV. Has the patient's bacteremia cleared? If it has not, then we will continue intravenous therapy. Is the patient likely to absorb from the gut? If no, that will be parenteral therapy once again. And are there any psychosocial reasons to prefer intravenous therapy? If the question is yes, then we'll continue intravenous therapy. Otherwise, as soon as the patient can transition from IV to PO, then we can consider step-down therapy. So this is probably the chunk of why we actually start with IV versus PO antibiotics and can make that transition to PO eventually. So the effectiveness of therapy, either IV or PO, really depends on the amount of the concentration and the antibiotics that will reach the region where the bacteria is present. So it's really the amount that is present in the blood and the amount that actually reaches the site, as well as the concentration. So the amount of blood that reaches the site is the peak blood level, and the concentration is correlated to the MIC, or the minimum inhibitory concentration. So really, I enjoy taking a look at the peak blood level to MIC ratio, even though I think my face is blocking one of the values for the Bactrim, which is trimethoprim sulmethazole. The ratio there, I believe, was around 22, versus if we were to take a look at other medications like tetracycline, where the peak blood level to MIC was 0.125, as well as, for example, the lowest value that I can see on my screen is sulfamide, which is 0.8. So as you can imagine, if we were to transition to PO antibiotics, maybe we'll consider medications like Bactrim, which has a peak blood level of 100, even though it doesn't have the lowest MIC, but can still be pretty reliable in these cases, especially in the cases of treating Staphylococcus aureus species. So introducing the PO trial, this is the partial oral versus intravenous antibiotic treatment of endocarditis. And really, to summarize for you, I made the chart. It's really taking a look at the PO versus IV. So, for example, they did two study groups where one arm was the intravenous trial was started and they continued with intravenous treatment, versus the other arm of 200 participants. In total, there were 400. One arm had 200. The control arm had 200, and the study arm had another 200 participants, where they used PO transition and step down to PO to see which one was more advantageous. This was an open label randomized non-inferiority trial, and they took a look at the primary outcomes composites of all-cause mortality, unplanned cardiac surgery, embolic events, and relapse of bacteremia. And the conclusion was that oral antibiotic therapy can be an effective alternative to IV therapy for selected patients with left-sided endocarditis after initial stabilization with IV antibiotics. So really, the findings and conclusion, I think the chart really summarizes well from the study. These are all the primary composite outcomes. If you take a look at the unplanned cardiac surgery, embolic events, and relapse to bacteremia, the percentages of intravenous to oral treatments are almost indifferent, and this is why this was a non-inferiority trial. So we have 6 to 6, 3 to 3, 5 to 5, with a 0% in indifference, with hazard ratios being the same. But there is a difference in all-cause mortality of 13 versus 7, with 3% change in difference, with a hazard ratio of 0.53. And this really shows that oral antibiotics are non-inferior to IV antibiotics. So we are able to start IV antibiotics for 7 to 10 days and then transition to step-down therapy with oral antibiotics that we've discussed from the previous page. So to really conclude this, we take a look at the what are the different types of endocarditis, the left side versus the right side, pathogens and the players. We took a look at the pathophysiology. We compared the left side and the right side as well. We discussed the PO trial, which concluded that PO step-down therapy from IV is not inferior to just continuing IV therapy when it's appropriate. And we took a look at the primary outcomes of the PO trial. Some of the things that were interesting for me during the studying for this material, is that I learned that talc is the most common material that is introduced to the right side of the heart, and that we don't necessarily have to initiate anticoagulation for endocarditis embolic events, simply because it's not indicated for blood clots. So here we will wrap up here. I'm more than happy to come in and answer any more questions. And of course, if the team has more questions, I'm more than happy to create another topic. All right, guys, take care. Bye-bye.